string sign. You know what is a string sign. It's not a contraindication for angioplasty. And sometimes you have to do that. Excuse me. So, a patient, 62 years old, diabetic dyslipidemia, with triple vessel disease, with unstable angina. And just before angioplasty or surgery, we discovered a very tight stenosis. Patient was asymptomatic. You will see a very tight right carotid stenosis, a long lesion, 40 millimeter, greater than 95%, and a duplex scan hypoechogenic plaque. So, excuse me, high-risk plaque. So what to do before a coronary revascularization? Maybe you could ask, what to do? You have a patient, you have to refer to the surgeon, or maybe you have to do angioplasty for triple vessel disease. You discover, excuse me, a very tight stenosis. What to do?
Should we take the audience poll? Or
yes. Oh, yes.
Audience poll, a tight asymptomatic unilateral carotid stenosis needing coronary revascularization, what would you do? Coronary first, carotid first, simultaneous. And second question, if carotid, an endarterectomy or an angioplasty.
Angioplasty.
Those for nothing, we go ahead with the coronary revascularization, please raise your hands. None. Those who would like to do a carotid endarterectomy, raise your hands. 2. And those who would like to do a carotid angioplasty.
Okay. So the majority may be for
yes,
angioplasty.
Verdict.
Yes. So what you have to avoid is a combination of surgery and carotid angioplasty, because you know that the risk of carotid angioplasty at the same time with surgery is very high, greater than 10%. So avoid that. So we took the option doing carotid angioplasty. So you see this very tight stenosis, string sign, very low flow. I don't want to show the CD. Very low flow into the brain too. So, which device you could use? Filter, proximal protection. So at that time we had no proximal protection, but that's a good point. Maybe proximal protection would be a good option. But we can discuss that. So you had only the option of a filter. So even with a very tight stenosis like that, you can try to cross with a filter. And we succeeded to cross with the filter, and you see, we place the filter here, just above the lesion. So even a very long, tight lesion, you can cross with a filter in more than 99% of the cases. So after that, you see, the filter was in place, and we predilated with a small coronary balloon, 2.5, and we predilated 2 times, and we had a lesion of 4 centimeters. And after that, you see the flow. Now it's patent. And we implanted a long wall stent. We dilated the wall stent and we removed the balloon. What happens? We checked total occlusion of the stent. What to do? What to do? You remove your filter. Other thing to do? What to do? Okay. So you can do that. Two options. You have to aspirate. What you don't have to do is to remove the filter when you have that, because if you remove the filter, you embolize a lot. Because it means the majority of the cases, it's good due to a spasm, but it's the filter which is totally blocked by debris. So you have to aspirate. So we took an aspiration catheter, a percussor aspiration catheter, and we aspirated 5-6 times, removing a lot of debris, thrombus, etc. And after that, we removed the filters, and we had a nice flow. So, the point, the take-home message is not to remove the filter when you have a low flow or a blockage when you have placed, dilated the stent. You aspirate either with aspiration catheter or with the guiding catheter. And with the guiding catheter, you can enter inside the stent and aspirate also. So that's a good technique. And you can see a very good flow, and now a very good flow to the brain. So, several points. String side is not a contraindication for angioplasty. And recently, Reimers at Miami meetings reported 20 cases of string sign done by angioplasty with very good result, no complication. So it's not a contraindication. If we can discuss the problem of indication of angioplasty or surgery before surgery or coronary angioplasty. It's another problem. This patient was asymptomatic, yes, but it's very smooth lesion, high embolic risk plaque, 95% string sign, so I think it's an indication because the risk of stroke is very high. So that's some point I would like to discuss with you. A point with the reversal flow technique. It's maybe a good technique, but don't expect to resolve all the problem. Recently, Nick Hopkins reported the American study with the parody device, the Empire study. With the parody device, reversal flow technique, the death stroke rate at 1 month was 3%. So it's not better than with any filters. So in my experience, the indication for reversal flow technique is very few indication, maybe 2%, because it's more cumbersome and the complication rate is the same as with any filters. And with a reversal flow, you can't aspirate inside the stent. You can't clean up the inside of the inner part of the stent. And for me, it's important now when you do a carotid angioplasty to clean up the inner part of the stent to avoid delayed embolic problem. Because you know that in neurological complication after carotid stenting, 50% of the complication occurred post-procedure. That means that you do a good job, you place a stent during the procedure, just after you have no problem, but you may have delayed embolic problem. And these delayed embolic problems are due to the thrombotic material which protrude to the stent struts. And you have to clean up this inner part of the stent. And with your reversal flow technique, you can't do that. So that's the reason. You don't expect better result. You have good indication with clots, with very tortuous vessel, but it's maybe 2% of the cases, no more. That's my feeling. Okay?
Yes, there's a question there. Yeah.
What is the size of the filter, Dr. Michel? The size of the filter, it's a string sign, there is no flow beyond the stenosis. So how do you size the filter? What size should you take?
The artery was maybe 4 millimeters, so we use an EPI for a vessel of 5.5, but it's a very small vessel because of the flow. But when we reopen the vessel, we enlarge the vessel, but we size depending on this vessel. API filter is good for small vessel, but not for large vessel. If not, you have to place the API very high.
So you should go with the standard 5 millimeter API maybe, when you have a string sign?
It's the eye. Yes.
Difficult.
Yes.
Okay.
Well, ladies and gentlemen, this is a interventionists gathering, but let me do the harakiri of propounding the other side also, because I'm a hardcore cardiac surgeon. I mean, we would, in India at least, also take into consideration the costs. So in a situation like this, when a person is going for a coronary vascularization, there is some merit in doing a combined procedure. And we have an experience of almost 100 plus cases. Tarun was here, or is he still here? Where we would, in all these patients, take up these patients, do the carotid endarterectomy first, leave the wound open, not close it, go on to the chest, finish the bypass surgery, reverse the heparin with protamine, and then close the neck wound. It doesn't add at all to the operating time, because till such time the carotid endarterectomy is going on, the chest is being opened, internal mammary artery, and the conduits are being harvested. So it doesn't add at all to that, and I think the combined procedure has its merits, and science and society, as we say, cannot be separated. So, and more so all over the world, I suppose, in this consideration of financial, meltdown, one would have to keep the costs in mind.
I fully agree with your point. You see that yesterday also our Dr. Hirimat was saying that at his center, if there is I was asking him that, do you get any asymptomatic patient here in India? If you ask me, I have never had the opportunity to do a carotid stenting on an asymptomatic patient. They come only when they are ladkhadaifying and falling down or something and getting one after another symptoms. And then only they come and we do it. Now, Dr. Hirimat was also telling yesterday that he is getting patients who are asymptomatic, otherwise when they have found that there is carotid artery stenosis and requires a bypass surgery, he said that they are doing first a coronary carotid stenting and then a bypass surgery. I too find it is costly. A bypass surgery itself is also so costly. On top of that, you are going for a coronary carotid stenting with filter and all. We have to think about our country's situation, or rather all over the world situation. It was a very funny experience once. You must be knowing a very well-known vascular surgeon, that is Frank Criado from Baltimore. I was having a discussion with him about the using or any limitations in using of the filter device. That was also, few years back. There was a time when to do or not to do and all. He said that, very quietly, he said, if I don't use a filter, I don't get reimbursement.
I think what Michelle is saying that once you see no reflow, aspirate. So what he was saying.
I think it's impossible to accept what you said, not to treat asymptomatic lesion. You must know that 70-80% of the patients before a stroke are asymptomatic. In all surgical series, 70% of the patients are asymptomatic. So why surgeons operate asymptomatic patients? I think they're right. Because 70-80% of the patients before any TIA, any stroke are asymptomatic.
That is all due to
there are now
litigation.
Good indication and bad indication for asymptomatic patient. Asymptomatic, what does that mean? If you do a CT scan, if you have silent brain infarct, is it asymptomatic? That's indication. That's clinically asymptomatic, but it's not asymptomatic. If you have very homogeneous plaque, very smooth plaque, it's indication. If you have brain function deterioration, it's indication. So don't say asymptomatic patient always the same. No, you have good indication and bad indication, and you have to select patient, but you have to treat asymptomatic patient.
Dr. Yadve, yes, Ardi.
Absolutely agree with the Dr. Henry. Because if you will see the stroke, if stroke occurs, it occurs. That means 1/3 will die, 1/3 will be disabled, and 1/3 will live with marked disability. So they won't be able to do the usual activity. So if it happens, it happens. You can't do anything thereafter. So it should be a prophylactic treatment. If it is required, it should be done. Regarding your question, sir, you said why not to do both. It's quite long, 4 centimeter. I think your clamp may not go up to that. You may not reach up to that. So I think intervention is the best procedure for this case. This case.
Okay, we close this and